Hey everyone, this is Ankit. Welcome to this episode of The Heart of the Matter. I'm joined by Anisha and Bourann, and we're going to be talking about the Fresh Up trial today. So this was a late breaking trial that was presented at ACC a few weeks ago, and we thought it was interesting, so we wanted to talk about it. To give us a little bit of background to orient ourselves, so there's not a lot of data on the effect of fluid restriction in heart failure, and there's no data that suggests that there's a beneficial effect of limiting fluid intake, especially in when considering heart failure hospitalizations and mortality. And actually, in some studies, there's some data that shows fluid restriction actually might have a detrimental impact on patients' quality of life, and that'll also affect their adherence to the fluid restriction itself. So the European Society of Cardiology, heart failure section, kind of highlighted this as a need for further clinical trials to address, and we thought about talking about the Fresh Up trial to highlight that need. So the Fresh Up trial basically assesses the effects of a liberal versus a restrictive fluid restriction in patients with chronic stable heart failure in an outpatient setting. And I'll let Bourann talk a little bit about the methods and results.
Yes. So the way this study was designed is that it is a randomized open label trial. This occurred in Netherlands, and it was across 7 different sites, and it included 504 patients that were randomized into either the group with the lifestyle recommendation of liberal fluid intake with no specific restriction, or a fluid restriction of up to 1,500 mLs per day, and this was over the course of 3 months. The inclusion criteria for patients to be a part of this study, which I will go bullet by bullet, but generally speaking, are chronic stable heart failure patients, and these are not patients with advanced stages of heart failure. So ages greater than 18 and patients who have been treated for chronic heart failure for 6 months prior to randomization. These are patients with NYHA class 2 or 3 heart failure symptoms, and any ejection fraction was acceptable. So preserved or reduced EF patients were included in this trial, provided that they were class 2 or 3 heart failure symptoms and that they were stable. Exclusion criteria, which again, similar to what I was saying about inclusion criteria, this is mostly excluding patients who have decompensated heart failure, recently decompensated heart failure, or any major changes to their heart failure status. So heart failure hospitalization within 3 months prior to randomization, any coronary intervention or implantation of a pacemaker within 3 months of randomization, any changes to medical heart failure therapy within 14 days before randomization, and then also additionally we have exclusion of patients who have a GFR less than 30 or hyponatremia. In terms of the outcomes of our study, the principal or primary outcome was to assess the responses in the Kansas City Cardiomyopathy Questionnaire, which is a validated tool that we use to assess functional capacity and symptom management in our patients with heart failure. And so what they actually found is that in the liberal fluid intake group, they had a score of 74 on the questionnaire versus a score of 72.2 in the fluid restriction group at the end of 3 months. Ultimately, this was not a statistically significant finding. With that being said, it was relatively close, as you can see, like I said, a score of 74 versus 72.2. There was a secondary outcome, and there is this other tool that we called the thirst distress scale. This is another subjective tool. This one is not validated, but it assesses a patient's perception of thirst. And so in those patients, there actually was a difference in perceived thirst distress. So in the patients who had the fluid restriction, they did have an increased perceived thirst distress at the end of 3 months. In terms of safety outcomes, so morbidity, mortality, death, all-cause hospitalization, these types of things, there was actually no statistically significant difference between patients who were in the liberal intake group versus restricted fluid group. But it's also important to mention that the just incidence of these events was quite low in general. So from a statistical power standpoint, it's hard to actually say that there was a meaningful difference. And like we said, the sample size of this was small overall. So that's what the study found. And there are a lot of things I think that we would like to talk about regarding this study. So we can start with that.
the thirst. So we could definitely talk about this thirst distress um, scale, but also just the way that they observed and reported the liberal versus um, fluid restricted in the study. So I think the most interesting thing to me about this was that the way that they measured liberal fluid intake was that they measured it for a week, which is, I think, a relatively short period of time, even though the overall study was only 3 months, which also I think is a relatively short period of time. Um, and they it was just a week, and then after that they did not measure at all. So the overall averages of the reported average of fluid intake was about 1850 versus 1500 in the fluid restriction group, right? So they used this as a benefit in the liberal fluid intake group so that they didn't have to think about or report in their daily life. And I understand that this was something that they used to try to make sure to really get a good idea of what it was like if people were able to go about their day to day. But I don't know how accurate it is when you only measured a week of it, outside of that, because I think that there are different things going on in our lives. People are, whether what the weather is like outside, how much you're drinking really varies. And I think also the thing that we will definitely emphasize is how much salty food are you eating? The other thing that this study has not brought up, or that we, I guess, haven't even acknowledged the elephant in the room, is that water follows salt, and we're not measuring the salt intake of either group of these patients. So I think that that's, I guess, one of the two big things that we really noticed. Additionally, you know, this obviously is an outpatient, stable heart failure population. I would say that the fluid restriction that we focus on or really talk about is in the inpatient setting when somebody comes in with a heart failure exacerbation, patients who have more unstable heart failure, or if they have had more recent hospitalization, or if they have hyponatremia, they were all excluded from this study. So how do we apply this on patients who, of course, we will do the things that we need to do in the hospital, but how can we apply the actual impact of fluid intake on heart failure exacerbation? I think that's the real extrapolation that we are unable to make um, in this from this study. I think that it was a good thought, and I think that what it does is it allows freedom for our stable heart failure patients to maybe drink freely in some way. But will I still be encouraging them to do that? Likely no, especially with the fact that many of our patients also have comorbidities. Nobody, I don't think I have a single patient that their only problem is heart failure. I'm not sure if either of you can think of anybody, but I think that that also makes this difficult for this to fully extrapolate as well, to our patient population, specifically in Detroit and residency, but also just in general as we move through our careers. The last bit that I want to bring up, which there's a lot to talk about, and I know that my colleagues want to comment on the things that I'm mentioning, is that this study was white, male, 67 or 68% white and male and of European descent. That doesn't reflect the global heart failure population. And this has all been acknowledged by the study itself. So it really makes these results less generalizable just to women, patient that all have heart failure, of course, and also other racial groups. We obviously don't practice race-based medicine, but there is a there are different disparities and different outcomes based on zip codes, especially somewhere like where we live currently in practice. I will open up the floor after my extensive commentary because this study was extremely interesting to me when Ankit and I both went to ACC. We were there when it was presented and when it was released in Nature the same day. And I think it was just immediately piqued our interest because it's just such a bread and butter thing that we deal with and talk about when we have our heart failure patients. So I will open up the floor.
Yeah, Great job, Anisha. I think you really talked about a lot of the things that we were thinking about while we were listening to the talk itself at ACC. One thing that I wanted to bring up, and Baran touched on a little bit, like the KCC quality of life scale. Obviously, it is validated, and the study did show it was statistically insignificant, but the p-value was like 0.056. So, I mean, if it had a larger sample size, it may have been powered enough to make it significant. So that's one thing. The other thing, though, it does seem like the functional status does not correlate to the clinical outcomes. As Baran said, there was no difference in any of those hospitalizations, use of IV diuretics, all those things that they assessed as, some of those secondary exploratory outcomes. Um, and yeah, and then the other thing you mentioned, Anisha, was like the timeline. Like this is only like 3 to 6 months worth of data. Again, I understand that this is important and it fills a need, especially in the outpatient setting, but in the inpatient setting, when you see a large spectrum of patients with heart failure, anywhere from, AHA stage C and D or NYHA 2 to 4, like you see those, and I don't know if this necessarily adds that information and answers that question whether fluid restriction actually helps or hurts.
I mean, I also just don't know if we would feel comfortable in an outpatient setting just telling our patients, even if they're stable, to just eat and drink however they feel when we know the impact of water and water following salt, and we know the impact of salt on our kidneys.
Yeah.
Ron, any thoughts?
I agree with everything you guys said. I think we mentioned this briefly before, but the other thing that I just keep thinking about is that when they actually assessed the amount of fluid intake in the liberal fluid intake group, they found that it was only 34% of patients that consumed more than 2,000 mLs per day. So what we're basically saying is that our patients in the liberal fluid intake group, at least for the week that we actually measured them, were not liberally intaking fluid in the way that you maybe would expect them to otherwise, because if we have half our patients who are taking in 1,500 or less, and then the majority of the other half are just taking in 500 mLs more in a day, that's not to say that that's totally insignificant, but I think this is maybe not quite evaluating what like true liberal fluid intake could have as an impact on our heart failure patients. And so whether that is because when people actually track their fluid intake, they consume less than they would otherwise, or whatever the case is, I think we may not have in this case truly examined liberal fluid intake, like somebody who is consuming 3 liters of water a day. And so we're not maybe assessing that to the highest degree. And then everything you guys said about salt intake as well, that's an important consideration for our heart failure patients. And so I think if we could have a study like this that limits, salt in one group, fluid in one group, salt and fluid in one group, and neither in one group, that maybe we could like actually piece by piece be able to see what has an impact on our chronic stable heart failure patients. While we don't see a lot of those people in the hospital because they're usually decompensated in the clinic, that is the majority of our patients if we're, usually if we're doing the right things for them and they're on the right treatment. And maybe with that information, we could actually give them a little bit more secure advice in terms of their fluid and salt intake. So those are my thoughts.
Yeah. Last thing I want to say, I know you guys talked about it earlier, but like the thirst distress scale, it's not super validated and hasn't really been correlated to assess quality of life, or at least how effective quality of life is based on the test. And yeah, I think that's pretty
I
much
want to say just one more thing about that, Ankit, is that, they all knew that they were being counseled on how, being in one group or the other prior. The study authors themselves mentioned that the advice that they could have had an effect on the outcomes. And also, if you know that you're in a group of people where your water intake isn't being restricted, I inherently think human nature, you would just feel like, oh, I can drink however much I want, so I'm not thirsty, or I can drink whenever I'm thirsty versus, oh, I could be restricted. I mean, obviously there's a huge psychological component in medicine, right?
yeah.
But I just think that we just can't take that out of it, and of course they all had to be aware. So I think that's another way that it makes it just tough for this to be to extrapolate this information and to use it in our patient population. I think overall, like you said, Ankit, it fills a need, and that it starts by thinking and answering this question. A small group of people, around 500 people, and I think there's a lot to be done. I think it's more spicy to do the drug trials and do all the other interesting trials, but I think this is the bread and butter of heart failure and learning more about how we can help our patients on a day-to-day basis. I think this was a really exciting trial in that front. I think we just have a lot more work to do.
Yeah. And then again, I know we could talk forever about this stuff. Lastly, I want to mention, like, especially with the KCC stuff, like the difference is too, like, it might not seem much from like an average, population level, but patient level, it is a significant difference. That's what I wanted to just keep it out there. So functional status does matter. Like, it's important. Like, quality of life does matter.
Okay, so today's fun fact, or question will be, if you could have one dessert for the rest, some that they're always food related. I love talking about food. If you had one dessert for the rest of your life, what would it be? Oh, mine would be a chocolate chip cookie. I don't have to hesitate. Bourann, do you want to go?
Ankit, can you go first?
Honestly, I don't eat dessert like that, to be honest. My wife does, obviously, and I'll eat it with her when I have to.
But if there was one that if you could only have one forever.
Probably just ice cream. I think that's my go-to.
That's fair. I like desserts, so I don't know. I think, honestly, probably I like cold desserts the most, so probably like ice cream or like ice cream cake or something. I don't know, something like that. But Ankit, I do just want to say you don't consume desserts apparently that much. You only drink water.
Yeah.
You're just better than us, huh?
I don't know. I don't think it's that, but I'm just not. I don't have a huge. I just don't have a huge sweet tooth. That's literally it.
Okay.
Fair enough. Anyways, see you all next time. Thanks for joining us.
Bye, guys.
Yeah, thanks for joining.